HIV AIDS and women. Here we will see why women are more at risk of acquiring infection, some of the relevant statistics, socio-cultural factors and progression of HIV disease in women, and special issues related to women such as pregnancy and breastfeeding in the context of HIV AIDS. There is also a section on reproductive health and empowerment of women, and finally a case study. Before you start working on this topic, it is important that you go through basic facts of HIV AIDS. What is the importance of studying this? There are certain groups which are vulnerable to HIV AIDS. Women are one of those groups. AIDS was first detected in the USA in 1981 among male homosexuals. Initially, there were more men infected with AIDS virus than women, in the ratio of 10:1. But now, the number of women infected with HIV is increasing. By and large, HIV disease among women in the developing worlds has been acquired heterosexually, that is, from men to women. This is due to the following facts. First, HIV infection is transmitted more effectively during sexual contact from men to women. Second, lack of education and illiteracy among women. Third, cultural beliefs regarding the role of women in the family and society. And fourth, lack of economic power among women. All these factors influence the relative vulnerability of women and their access to means of prevention and support in the face of HIV/AIDS. Women who are infected with HIV infection can also transmit the HIV infection to others. For healthcare workers dealing with HIV-positive women, it is important to understand that psychosocial and cultural issues, as they have important implications for women, and related issues such as childbearing and breastfeeding. Let us look at the socio-cultural factors. The link between powerlessness and the risk of exposure to HIV provides the key to understanding the source of women's vulnerability to HIV infection. The social, economic and cultural subordination of women creates a context in which the woman succumbs silently to scourge. Following are some of the factors that make an Indian woman not only more prone to HIV infection, but also less likely to seek medical attention. Early sexual intercourse. Culturally, initiation to sexual intercourse begins several years earlier for females than for males. Many women are still in third mid-teens when they marry. Often women get married to much older men who are sexually more experienced. Therefore, chances for women to get HIV infected from a husband who might be indulging in sexual activities outside marriage are higher. Source of infection. In the developing countries, nearly all HIV infection reported among women has been acquired heterosexually. Majority of the Indian women have been infected not through their own behavior but through that of their husbands. An Indian woman has greatest risk promiscuous of HIV infection in from her husband. Lack of choice. In marriage, women lack control over their lives or over that of their husband's life outside the marriage. Extramarital relationships, intravenous drug abuse, and bisexual behavior on the partner of the husband are possible routes for entry of the virus into the marital union. For these women, sexual intercourse is not a question of choice, but rather a question of survival. The wife has hardly any say in matters such as when to have sexual intercourse or how to protect herself from HIV infection. She also does not enjoy the freedom to choose whether to become a mother or to protect the life of an unborn child from forced abortion. Poor access to health, education and care. Women are looked upon as child bearers and child rearers. In the sociological division of labor, they have greater responsibilities towards the children and home. There is limited access to information, education and mobility. Also, more often than not, there is shortage of financial resources to pay for the use of healthcare facilities. Blame. It is an unfortunate reality that when the first case of HIV/AIDS is identified within a family, the blame is most often placed upon the women, even if the evidence contradicts this. There is fear that her family, because of her perceived past behavior, will abandon her. She is forced to keep quiet and she is not in a position to argue her case. Isolation and stigma. HIV positive women feel extremely lonely and isolated. Fear of social stigma compels them to keep their seropositive status a secret. They have a fear of being abandoned by family, friend, and the community. Delay in diagnosis. Indian women are often unaware of their HIV positive status, or they may be the last one in the family to know their diagnosis due to the power hierarchy in the family structure. Some women discover that they are HIV positive by accident, usually after the husband or child is found to be symptomatic with an HIV related disease. The woman will then be dealing with two crises, that of illness of her husband or child, or both, as well as her own illness. Emotional response. Suddenly, upon discovering the HIV positive status of spouse, the woman has to deal emotionally with her husband's unfaithfulness. She may feel anger towards her husband, grief at the loss of health and status, and guilt relating to how she may have been the cause of illness in her own family, particularly for her children. She may also be filled with anxiety and worry, undoubtedly. The situation is stressful and one in which there is a lot of uncertainty about the future. Dependency. In India, most women are dependent on their husbands or his family for food, clothing, shelter, and money. It is the male partner who usually controls the financial matter at home. As a result of this, abstinence, faithfulness on man's part, and using condoms for protection, which has now become the mainstay of prevention of HIV infection, which is totally under the man's control. Burden and bereavement. From the time of her birth, the Indian female child is considered a burden, initially for her parents, later on for her husband's family. The main aim of her biological family is to quickly marry her off. She is usually given minimum education and care before marriage. After marriage, in case of husband's death, his property and savings, if any, remains with the husband's family, and in many cases, the wife goes back to her own family where she continues to be a financial and emotional burden. Many such women are also forced into prostitution for a living. In fact, most women living on prostitution have a poor background, like desertion by husband, rape, migration to cities in search of job, forced flesh trade through kidnapping or sale, etc. Pregnancy. Women are considered to be potential bearer of sons. Many Indian believes that sons are the one who will grow up and earn and look after the old parents, while daughters are a burden who will have been given away in the marriage. Even if a woman is HIV positive, she may be under pressure to produce a son at risk of her own life, as well as that of her unborn child. HIV AIDS in women. Reasons for transmission. Some of the reasons for transmission of HIV disease to women are sexual promiscuity. Worldwide, the cause of transmission of HIV to women is the prevalence of heterosexual promiscuity. Research indicates that the male to female transmission of HIV-1 is relatively more efficient than female to male transmission. Sexually transmitted diseases. STDs, particularly those associated with genital ulcers, lead to increased risk of HIV infection. Non-ulcerative STDs, gonorrhea, chlamydia, trichomonias, and bacterial vaginosis also have been associated with increased risk of HIV transmission. Drug abuse. In Western countries, at the beginning of the HIV/AIDS epidemic, drug use was one of the major factors in women acquiring HIV. Drug use in women is associated with sharing of unsterilized needles for injecting drugs and high-risk sex behavior with multiple partners. Dominance of the spouse. The inability of the woman to compel her male sexual partner about using barrier contraceptives such as condoms, etc., place her at risk of acquiring HIV infection and other sexually transmitted diseases. While research is still on, some studies are there on the role of oral contraception or intrauterine contraceptive or IUD device such as loops, copper T, etc. in increasing the risk of HIV infection. Oral contraception may thin the vaginal epithelium, making it easier for HIV transmission, and IUCD may injure the mucosa and help to transmit the HIV virus easily. Viral factors. Viral load and viral characteristics play certain role in the risk of a sexual transmission of HIV. Higher the viral load in the semen and vaginal secretions, greater the risk of transmission. Also, certain subtypes of HIV virus may be associated with certain types of transmission, but again, this has not been conclusively proven. Signs and symptoms. There are no difference in the manifestation of HIV infection among men or women. As in the male, the female also, once she has become infected with the HIV AIDS virus, may not have any signs or symptoms at all. In a significant percentage of people, at the time of seroconversion, when the antibodies are formed, there may be flu-like illness with fever, body pains, rash, headache, etc. This may last for few days to weeks and then disappear. The HIV-infected person may then not have any more signs and symptoms. She may continue to do her routine work of cooking and caring for children with a sexual relationship with her husband. Her blood test may be done only when her husband or her children become sick. Later on, as her CD4 count begins to fall, she becomes prone to other infections called opportunistic infections. Opportunistic infections, fungal infection of the throat and esophagus, the hollow tube that connects the mouth to the stomach, is a common opportunistic infection in women. Recurrent bacterial pneumonia and lung infections are more common in women. Other infections commonly seen in HIV-infected women include recurrent mucocutaneous infection, herpes simplex infection, mucocutaneous candidiasis, toxoplasmosis, tuberculosis, and cryptococcal infections. Gynecological infections. Infections of the reproductive tract are referred to as gynecological infections. Gynecological diseases in HIV-infected and non-HIV-infected women are the same. Certain diseases are more common in the HIV-infected women. Extensive herpes simplex ulceration may be seen in HIV-infected women, and it may be resistant to standard treatment. Vaginal infections such as candidiasis, trichoniasis, and bacterial vaginosis may be more common. Apart from the usual cause of genital ulcers like syphilis and cankeroid, HIV infection can also cause genital ulcer. Pelvic inflammatory diseases are commonly and more aggressive in HIV-infected women. Immunosuppression has been associated with consequences of human papilloma virus (HPV) infecting, including cervical cancers, HIV-associated cancers, and precancerous conditions in women. It is noted that HIV-positive women have higher risk of acquiring cancer of the cervix. Due to the loss of cell-mediated immunity in HIV-infected women, they tend to develop HPV or human papilloma virus infections, which are associated with precancerous lesions. The common occurrence of HPV infection, often of multiple layer, and rapid progression of cervical intraepithelial neoplasia, and the high rate of reoccurrence in spite of therapy and multiple lesions makes this an important area of concern in HIV prevention. Treatment. In HIV diseases, one has to consider two regimes of treatment: specific treatment for HIV infection, treatment for opportunistic diseases. Drugs that are given for specific HIV diseases are called antiretroviral drugs, and several drugs are available. These drugs may be given in double or triple drug combination. These drugs are very expensive and beyond the reach of the common man. For opportunistic diseases, there is a specific treatment depending on the disease, such as tuberculosis, candidiasis, toxoplasmosis, cryptococcus, and cytomegalovirus infection, etc. HIV AIDS, progression, and overall survival of infected women in comparison to men. In the late 80s, reports suggested a less favorable outcome of HIV-infected women in comparison to men. But more recent studies have not confirmed this finding. Majority of research data suggests no difference between women and men in HIV disease progression or survival. HIV AIDS and pregnancy. It has been reported that HIV AIDS is spreading from the high risk behavior group to the general population. This is corroborated by the fact that a significant percentage of pregnant women who are tested for HIV in the antenatal clinics are positive, and this percentage is now increasing. There are several issues to be considered in the case of HIV positive mother and pregnancy, and these issues are: HIV infection does not erase women's desire and hopes for sexual bonding, intimacy, and childbearing. In India, a pregnant woman is considered to be the potential bearer of a son. Her social status improves after the birth of a son. This culturally prevalent attitude should be kept in mind when counseling the HIV positive women of childbearing age. The pregnant HIV positive mother chance of bearing an HIV positive child is 25 to 30%. This transmission from mother to child can occur during pregnancy itself, or at the time of childbirth, or during breastfeeding. The stage of HIV infection in the pregnant mother is also important. If it is in early stage of HIV infection, pregnancy has little, if any, effect on HIV infection. However, in later stages of infection, especially if the mother has HIV AIDS, the pregnancy can be more complicated. It is very important to help HIV positive women and their husbands assess the risk of giving birth to an infected child. They should consider the possibility of having an infected child, or if the child is uninfected, who will care for the child in the event of their own illness or death. Counseling should help the woman develop a plan of how she will care for her child, how her family and community will help her, and how she expects to support and care for her child if she becomes sick and dies. Whenever decisions are about avoiding or terminating a pregnancy, or about preparing for a possibly infected infant need to be made, they should involve both the parents. Such couples should also discuss the matter with their religious leaders or spiritual guides. The mother and her family will require psychological support during the pregnancy. She should be advised upon having regular medical checkups, use of medications, and consider delivery in a hospital. Effect of HIV on pregnancy. Data from developing countries show that HIV infection among pregnant women is associated with increased rate of preterm delivery, low birth weight, and stillbirth. This has not been seen in developed countries. Risk factors associated with transmission. The risk factors associated with HIV transmission from mother to child may be subdivided as virologic factors, maternal factors, placental factors, fetal factors, birth canal factors, obstetric factors, and newborn factors. Let us look at them one by one. Viral factors. High viral load in pregnant mother could lead to high risk of transmission of the HIV to the child. Maternal factors. Sexual intercourse with multiple partners during pregnancy could lead to increased risk of transmission. Low CD4 counts in mother could lead to high risk of transmission to child, as also the stage of the syndrome in the mother determines the risk of HIV transmission to child. Prevention strategies. Less frequent intercourse, sexual relationship with one partner, and use of barrier contraception are important for prevention of HIV transmission. Vitamin A supplementation to mother and antiretroviral drug therapy to reduce the viral load in women. Placental factors. HIV can be isolated from the placenta. Any placental disruption could lead to higher risk of transmission, and this can also happen with chorioamnionitis, cigarette smoking, or illicit drug use and sexually transmitted diseases in the mother. Factors during delivery. Factors responsible for HIV transmission during delivery include amount of virus in the genital tract, the infant's thin skin and mucous surface which can absorb the virus during the birth process, breaking of waters, any bleeding during labor, and prolonged labor after rupture. It is recommended that one may opt for cesarean section to reduce the chances of HIV infection during delivery. Prevention strategies: antiretroviral therapy to prevent infection of the placenta. Treatment of STDs, chorioamnionitis. Stop cigarette smoking and illicit drug use. Fetal factors. There are differences in the susceptibility of the fetal cells to infection by virus, and this may be related to genetic factors. Swallowing of infected maternal fluids during the delivery and labor by the fetus may lead to increase and chance of infection. Prevention strategies: adequate treatment of genital infections during pregnancy. Elective cesarean section can reduce the risk of infection. Vertical cleaning of birth canal before vaginal delivery may also reduce transmission. Preventive therapeutic intervention. As discussed, chance of the pregnant HIV positive mother conceiving and delivering an HIV infected baby is 25 to 30%. By giving the mother an antiretroviral drug during the pregnancy, and the chance of transmission can be reduced by 70% to about 80%. The drug most commonly used is called AZT, azithromycin, or zidovudine. Sometimes 2 or 3 drug combinations can also be given. The baby could also receive AZT for 6 weeks after birth. Recently, another drug is also found to be useful in reducing the transmission of HIV from mother to child. This drug is called nevirapine. It can be given as a single dose to the mother at onset of labor and to the newborn child as a single dose 72 hours after the birth. Any treatment should be under the authentic prescription of a qualified physician. One should never opt for any type of self-medication based on information received through learning materials of this audio lesson. HIV AIDS and breastfeeding. Transmission of HIV infection from a mother to her child can occur during breastfeeding also. However, fortunately, a vast number of babies breastfeeding by HIV positive mother do not become infected through breast milk. Chances of transmission during breastfeeding are higher if the woman becomes infected during the breastfeeding period and lower among the women already infected at the time of delivery. Breastfeeding is extremely crucial for child survival in our country and especially among people of the poorer socio-economic status. Breast milk provides all the essential factors that makes a baby healthy and protects it from other infections. Without breast milk, many infants can die from other infections or from malnutrition. A baby's risk of dying of HIV AIDS through breastfeeding must be balanced against its risk of dying of other causes if not breastfed. The general recommendation is that in countries where the infant mortality rate is high, breastfeeding should be encouraged among pregnant women, including those who are HIV infected. This is because the baby's risk of getting HIV infection through breast milk is likely to be lower than its risk of death from other causes. If the child is not breastfed, women who know they are HIV infected and for whom bottle feeding is an affordable option can resort to bottle feeding rather than breastfeeding. Sex workers. In India, as in other countries, commercial sex workers, CSWs, are often singled out for special attention in the context of HIV AIDS due to multiplicity of their sexual contact and high STD rates. Focusing on prostitution and its relationships to HIV infection has the detrimental effect of implying that women are responsible for the spread of HIV. They are viewed as transmitters for the HIV rather than a recipient. Nevertheless, prostitution is one of the list of behaviors which can lead to HIV infection because of the number of and the type of sexual contacts as well as the risk behavior of the partners. Studies indicated that commercial sexual workers in India avoid using existing health structure because of the harsh and inhuman treatment they receive at the hands of the medical staff. They are also unaware of the family planning services and how to protect themselves from STDs and HIV infection. They may seek treatment from quacks to remain anonymous and to avoid facing ridicule from medical staff. From the public health point view, it is very difficult to identify, educate, and counsel the large number of women who are at risk of acquiring infection through heterosexual intercourse. It becomes the goal of HIV prevention programs to educate all women about the risk of acquiring HIV/AIDS and to encourage adoption of risk reducing sexual behavior. Another form of high risk sexual act which is practiced in parts of Maharashtra and Karnataka is the Devadasi system, where young girls of poor families after attaining puberty are dedicated to goddess in temples through a religious ritual and later on channelized into prostitution. As this form of prostitution is linked to religion, it is very difficult to abolish. The reason why women go into prostitution may be many. Some are forced into it because they are destitute or uneducated and have no other means of livelihood. Some others may be even forced by their husbands or sexual partners, while several are drug dependent and need money to meet their habit. Rarely they do it because they want to. Risk reduction. Prostitution is found in almost all states of India. Many studies have revealed that a significant number of CSWs are HIV positive. Since the advent of HIV/AIDS, it is important to empower these women to protect themselves from HIV infection. By risk reducing behavior, whenever possible, CSWs have to be rehabilitated. CSWs must be provided with knowledge about STDs and HIV and the means to protect themselves. CSW must be taught negotiating skills so that they can negotiate with their clients for using condoms. CSWs must be provided with regular medical checkups so that STDs can be promptly treated. As part of their rehabilitation, CSWs must be encouraged to undergo vocational trainings. Many women are at the mercy of middlemen or pimps who are the link between the CSWs and their clients. Often, there are powerful men at the helm of affairs, and it may be very difficult for the women to leave their jobs even if they want to. Many HIV/AIDS prevention programs have been started by the governmental and non-governmental organizations which target the CSWs. The Sonagachi project in West Bengal is cited as an example of how CSWs can be empowered and educated to work towards HIV prevention. Drug addiction, HIV and women. There is an epidemiological relationship between drug abuse and HIV infection. Consumption of drug and alcohol reduces the inhibitions of people and increases the chances of risk behavior. In the Western countries, intravenous drug usage is a major problem. In those countries, a significant proportion of HIV infected women are IVDU, that is, intravenous drug users. Thus, ensuring inclusion of HIV infected drug users and understanding drug use related issues become the key challenge to obtain a comprehensive understanding of women affected by the epidemic. Rape, incest, lesbianism, teenage pregnancies and abortions. When a male has sexual intercourse with a woman against her wish, it constitutes rape. Incest is when there is sexual relationship between member of the family, father and daughter, mother and son, etc. Lesbianism means women who have sex with women. Homosexuality refers to sexual relationship between person of same sex, especially men. Teenage pregnancies occur among girls in their teens. An understanding of these specific issues become important in the context of HIV/AIDS because these groups run the risk of acquiring HIV/AIDS in addition to all other social, physical and emotional problems that they are subjected to. Another problem that exists in India is that of illegal abortions. These are still being practiced in the case of unwed mothers and those women who are unaware of or embarrassed to seek proper medical facilities. It is possible that HIV positive expectant mothers may avail of these facilities to abort the fetus, but hide their own HIV status and therefore other complications may set in. As these centers do not take infection control into consideration, the counselor must help and encourage women to avail of legal medical facilities. RTI, reproductive tract infections. It is important for women to know that their reproductive tract should be healthy and that very often women may have genital infections without even knowing that they have them. This is addition to all other factors previously mentioned place them at the increased risk of acquiring HIV infection. Why are women at risk? Women are at risk of acquiring sexually transmitted infections and HIV infection because their reproductive organs are structured in such a way. Also, almost 60% of all sexually transmitted infections have no symptom. Therefore, even a woman has one, she would not know it. Women at the time of childbirth may have several problems such as prolonged labor, cesarean section, or forceps delivery. As a result of these procedures, injury to the genital tract, blood loss, risk of infection are common. Therefore, it is important for women to take care of their reproductive health and have regular medical checkups, whether they have symptoms or not. How are STDs transmitted? Through sexual contact and with uninfected person, from mother who is infected to her baby during the time of delivery, from blood and blood products given to women. What are the symptoms of STDs in women? Many of the women are asymptomatic. They may have discharge from vagina which could be large in quantity, white or yellow in color, or false smelling. Women may have itching or pain while passing urine. Ulcers or blisters may be seen on vagina, vulva with or without pain. If these infections are not treated on time, then women may not be able to conceive and have children. The infection can spread from the vagina to surrounding areas and the uterus. She is also easily prone to acquiring HIV infection from an infected partner, and the infection can spread from her to her newborn child during her delivery. It needs to be highlighted that all programs of women welfare now have reproductive health as major component. Access to health care linked with women empowerment are the basic steps of successful HIV prevention program. Empowerment of women. In the Indian situation, a woman is usually completely dependent on her husband for food and shelter. The male partner controls all the activities. The woman is at risk if her male partner has sexual relationship outside marriage. She does not have the capacity or the authority to demand, and she has the right to protect herself from HIV AIDS and STIs, and therefore request her husband to be faithful or to use barrier devices when indulging in the activities outside marriage. Hence, in a majority of cases, the women become infected not through her behavior but through that of her husband's. And once she is infected, she is at much greater risk of facing all the medical and social complications of HIV AIDS. She is the one who is then blamed, stigmatized, and discriminated against. The issue of women is clearly a survival issue. In order to survive, women will need to know that they have a choice to say no to high-risk behaviors, a choice to protect themselves from infection, a choice to take care of their health if they do not want to get infected, a choice to make decisions regarding pregnancy, and choice to have a significant role in marital union lives. This act to make women aware of their choices to strengthen them in all areas of their lives is referred to as empowerment of women. Empowerment of women is one of the key issues in keeping women safe and healthy. In Western countries, there is Women's Advocacy and Right Group, which empowers women. Many of these groups are headed by and run by HIV positive women themselves. In 1970s, saw the rise of wave of NGOs known as social action groups, within which women's organizations form a distinctive band. They have taken the lead in the campaigns against sexual abuse, the dowry system, and violence against women. They also provide health services for women, vocational training, and income generating schemes. Here we have described in detail about how women are vulnerable to HIV/AIDS. The main point that have been covered in this section includes socio-cultural factors which influence the vulnerability of women to HIV/AIDS. HIV disease and its progression in women, special issues pertaining to women such as pregnancy, childbirth, and breastfeeding, and positive response to the AIDS epidemic such as empowerment of women and reproductive health.